thank everyone for joining us tonight for our first Wellness Exchange of 2024. I'm really pleased to be welcoming everyone on behalf of the Women's Health Research Institute, which is the only research organization in British Columbia dedicated to advancing women's health through research. My name's Gina Ogilvie, and I'm the Associate Director of the WHRI. And the Women's Health Research Institute functions as the face of women's health for the Provincial Health Services Authority, and is also the research arm for the BC Women's Hospital and Health Centre, and is a UBC Faculty of Medicine Research Centre. The WHRI is situated on the unceded ancestral and traditional territories of the Musqueam, Squamish, Stolo, and Tsleil-Waututh First Nations. And as a provincial research institute committed to improving the health outcomes of women in all their diversity, we recognize our responsibility in the collective efforts towards the establishment of culturally safe healthcare systems and services that address health inequities among Indigenous peoples, including Indigenous women, girls, and Two-Spirit peoples. We really encourage everyone who is connected to research to read both the Truth and Reconciliation Commission of Canada, as well as the In Plain Sight report, and reflect on the ways that we can incorporate the recommendations into our lives and our work. As we gather in spaces together, we encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. In our own organizational commitments and in our strategic frameworks to knowledge translation and patient engagement, we've created these events to provide a linkage between WHRI researchers and the public to really accelerate the use of evidence in women's health. And tonight, we're really delighted to have a particular focus on women's health innovation through research. When we think about innovation, it's not just simply inventing something new, something flashy, something we don't know about yet. It's also the process of implementing what is new into practice so it can have an impact and so it can have a benefit. At the WHRI, we support research that spans this spectrum from the innovation, from idea and concept all the way through to impact. And one of our areas of strategic focus in this innovation space is digital health research. Digital health research, we have a broad umbrella term for it, includes how we use health data to better understand how to care for our patients, and how we use digital tools and processes, such as mobile platforms and videos to educate and communicate with patients or between providers. And these are the stories of impact that you're going to hear tonight. We've really focused on the impact. So for the remainder of the evening, you're going to have the great pleasure of engaging with our event MC, Shirley Weir. Shirley has been our MC for years and has created her own community, Menopause Chicks, to share evidence-based information to support women transitioning through to menopause. She's a TEDx speaker, a regular guest with the media and podcasts, and a fierce advocate for science. We were thrilled to recognize Shirley as a recipient of our inaugural WHRI Community Champion for Knowledge Mobilization Award. Welcome, Shirley, and I'll hand it over to you.
Thank you, Dr. Ogilvie. Oh my goodness, I'm so excited that we are back online for the first Wellness Exchange of 2024. I think the last time we did this was in person. It feels like a long time ago, but I love doing online events like this because I know that we are reaching all corners of the province, the country, and maybe even the world. And the other reason that I am so honored to do this work is because I'm a knowledge transfer nerd. I am addicted to finding the latest research and innovation and what is happening. And then I have the great pleasure of every day working with individuals who want to access evidence-based information when they're making their own health decisions. So you are in for a treat in that regard tonight, because we have 3 fabulous presentations and incredible researchers and presenters. And I want to get us started right away. We're going to be together for about an hour. I invite you to find the Q&A along the bottom of your Zoom screen, or if you are joining us on Facebook, you can enter questions into the comments and we will be moderating those questions. So Dr. Catriona, thank you for joining us tonight. Take it away.
Thank you so much, Shirley. And thanks to the WHRI for this chance to be here tonight, and to all of you for coming and spending some time with us. Um, I'm really excited to share with you today how I developed the creating comfort and choice theory as part of my PhD, and how I'm now working with a great team to make it accessible to those who are facing the decision of whether to take antidepressants during pregnancy. First, I'd like to acknowledge that UBC and BC Children's and Women's Hospitals are on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And this sculpture by Fred Dobbs and Nathan Scott is on the BC Children's and Women's Hospital campus. And I found it really beautiful and inspiring. And I noticed in particular this parent cuddling a baby otter and found it really touching. And I looked into and found the creation story of the otter on the website for the Canadian Museum of History. You can listen to the whole narration on the website that's hyperlinked here. I'm happy to share my slides, but I wanted to share just a little bit of it with you now. From the oral history of an unnamed Anishinaabe knowledge keeper, when the Great Spirit created the earth, the guardian spirit of the otter offered to help humans by showing them the direction to unity. The Great Spirit approved and chose the otter to be the guardian of unity for the Anishinaabe. And even though this story is not from the Musqueam, Squamish, or Tsleil-Waututh peoples, I think unity is desperately needed these days. And it's lovely to think of this force of unity represented by parent otters cuddling baby otters. Which brings us back to what I'll be talking to you about with caring for parental mental health at the transition time of bringing babies into this world. This is an important public health issue because depression during pregnancy is common, affecting approximately 10 to 15% of women and even up to 50% of immigrant and Indigenous women. And it can happen during pregnancy as well as postpartum. In fact, research suggests that often as much as half the time postpartum depression starts during pregnancy. And symptoms of depression like sadness or lack of energy, lack of interest, that happen at any time are also happen in the perinatal period. But often the symptoms of depression in pregnancy or the postpartum are focused around that experience. For example, feeling like you're not a good enough parent. And there can be a lot of feelings of guilt, for example, around breastfeeding, or maybe around feelings of guilt around taking medication. And that was part of the motivation for some of my PhD work. We know that antidepressants are helpful for treating depression, and they're one of the most accessible and affordable treatment options. However, when it comes to pregnancy, society expects women to abstain from many things, including medication use. And women are faced with these types of alarming headlines that don't reflect all that we know from research, which is that the risks to the fetus of antidepressants during pregnancy is about equal to the risk of untreated depression in pregnancy, which is why clinical practice guidelines recommend that clinicians support people to make an informed choice about depression treatment. But the practice guidelines don't say as much about how to do this. And that's partly what the focus of my work was on. I published a narrative review of literature, which was basically looking at, what's been out there, what research has been done on women's perspectives of making this decision. And there were some studies that had been published that had investigated this question, and they did offer some insight, but to be honest, the findings were relatively superficial, with a main take-home message being that women needed to balance the risks and the benefits. But that left the question of how women do that mostly unanswered. So I set out to try to answer it. And I did that by interviewing 31 birthing people who all identified as women. And I connected with them through their attendance at some specialty clinics at the BC Women's and Children's Hospitals, and also through posters or advertisements, connections, and in the community. And and then I did the interviews and recorded them, and they were either in person or by phone. This was kind of pre-pandemic, pre-Zoom era, and then they were transcribed, which basically means that they were written down. And I used an analysis method called constructivist grounded theory, which basically means that I looked at those written versions of the stories that women had shared in the interviews, and I looked for ideas that were shared or unique in the interviews to make connections between women's experiences and see what's different and the same. And then I linked those ideas and connections to come up with the creating comfort in choice theory, which is represented here. And this grounded theory places the woman in the center of the model and the decision-making process. And you can see also that that decision-making process is happening in the perinatal period, which is then in turn within a societal environment, which is also influencing those decisions. And three emotions, anxiety, guilt, and fear, dominate her decision-making process. And then there are three clusters of decision-making activities represented in these gray circles, which are seeking information, making sense of information, and self-soothing. And I wanted to highlight a few things that came up from my discussions with the participants. One was that those strong negative emotions that they experienced when they were making the decision was at least partly related to pressures that they felt from society. There are many sources of pressure that are acting on women at this time. The stigma of mental illness, for people who were taking medication, or stigma for taking medication, and also societal expectations in the pregnancy or postpartum that really compound at a time of great vulnerability for women. And in particular, women felt pressure to put their baby's health before their own health. This picture of a book cover was shared with me by one of my participants, who said that it did a really good job of representing how she felt during pregnancy, with that baby being like so much more of the focus than the mom. And to me and to many of my participants, this pressure is related to our patriarchal society that tells everyone that the health of a mother is less important than the health of a baby. And another pressure in our society is the pressure to do it all on your own. We prioritize independence and autonomy, and that can be good, but it can also leave women feeling alone with the burden of deciding whether to take antidepressants during pregnancy and their anticipated guilt. So I wondered, how can we help women feel less alone? And one of the things that came up quite a lot in the interviews with participants was how helpful it was to people to hear stories of others and how they made the decision. One of my participants is an animator and suggested animating the theory. And I was really excited about that idea, and as a way to try and help others, feel connected to the bigger group of people who have made this choice. And we put together a case with the BC Women's Health Foundation, who was able to match us with a donor to support the project. And we released the animated video on World Maternal Mental Health Day last year, and I'm really delighted to be able to share it with you now. And the QR code here on the side will take you to the YouTube of this video if you wanted to look at it again later. And this QR code takes you to the publication in the peer-reviewed journal, which I realize now there was one on a previous slide too. And I know they could be behind some paywalls. And so if you have trouble accessing them, my email address is at the end of the presentation, and I'd be happy to share them with you. In this video, we share with you the Creating Comfort in Choice theory. It describes how women decide whether or not to take antidepressant medication during pregnancy. Women who faced this choice created this theory to help other women who are trying to make this same choice. In the center is a woman who has experienced depression. She is pregnant or planning a pregnancy. She is thinking about whether to take antidepressants during pregnancy. She might be thinking about this choice at any time before or during pregnancy. She lives in a society that expects women to sacrifice themselves for their children and that limits the choices women can make for themselves. This society doesn't provide equal access to healthcare, like therapy, for all women. It also judges harshly the experience of depression and the use of antidepressants, especially in pregnancy. Because of all this, she feels anxiety, guilt, and fear. As she thinks about whether to take antidepressants in pregnancy, she seeks information, she tries to make sense of this information, and she tries to soothe herself. She moves back and forth between doing these three things. In seeking information, she tries to understand what the risk of harm is to herself and to her baby. She thinks about her own experiences, for example, if she's taken antidepressants before. She talks about the options with her family, friends, or healthcare professionals. She looks for written information online or from her doctor. In making sense of information, she thinks about whether she can trust the information she has. She thinks about her own beliefs. She imagines what might happen if she chooses one option or another option. She tries to see the information from different angles. She tries to put all the information together to figure out what risks of harm there are with different choices. In self-soothing, she tries to manage her anxiety, guilt, and fear to try to get comfortable in the process or with a possible choice. She might repeat a mantra to herself like, "I'm doing the best I can." She might reassure herself that she's not alone in trying to make this choice. She might block out scary news or unhelpful advice from others. She might work on a plan to protect her mental health. As she gets closer to choosing, she tries to connect the information she has gathered with her beliefs and preferences. She tries to resolve any conflict that she's come across. For example, if she would prefer not to take antidepressants, but her doctor thinks she should, she might seek more information, perhaps by talking to friends or family. She tries to see what's most important to her. She tries to feel comfortable with the choice she's reaching towards. If she does make a choice, she might come back to it later and either confirm the same choice or reach a different choice. Making these choices is hard. If you are trying to make this choice, resources include the BC Reproductive Mental Health Program, the Pacific Postpartum Support Society, and the ADAPT Clinic. Check out the links below. And the links below are on the YouTube description. So in terms of next steps, we're now, we have funding also from the BC Women's Foundation to develop documentary style videos to try to add more depth and nuance into the resources that we can provide to people who are making this decision. So we're looking for participants for those, and we're planning to have 3 videos. One sharing the experiences of people who have decided to take antidepressants in pregnancy. Another one of the stories of people who have chosen not to take antidepressants. And then a third one for people who are still undecided. So if that sounds like you or something that you would be interested in learning more about, this QR code here will take you to a page on my website that has a link to a survey to provide your information, and then we'll get in touch with you. Key takeaways from my presentation today. Depression is common in pregnancy and postpartum. And we know that the perinatal period is the most vulnerable time for mental health in a woman or gender diverse birthing person's life. We also know that taking antidepressants can be the best choice for women and birthing parents and their babies. Most importantly, if you're suffering, please seek help. I have some resources here. The new phone number 988 that's across Canada will connect you to suicide or crisis support if you're thinking of hurting yourself or need immediate support. I've also included here the websites of the Reproductive Mental Health Program and the Pacific Postpartum Support Society that have a variety of resources included on them. And the Pacific Postpartum Support Society also offers support by phone or text message. And then I've also got a link here to a podcast episode that I did with the WHRI that talks a little bit more about this work and some other work in the area. And I'd like to thank everyone who made this work possible. There's a huge team that have been supporting me along the way, and I couldn't have done it without them. And I'm happy to answer any questions that you might have, either now or by email in follow-up.
Thank you, Dr. Hippman. That was amazing. I really love your graphic knowledge transfer. That was incredible. And I think I don't see any questions in the Q&A right now, but I know that one of the key takeaways for me, or the light bulb, is that headlines can often lead us towards risk, telling a story of risk, but they often fail to tell us the risk of not doing something. So the importance of having that conversation or shared decision making. You really
Yeah.
drove that point home for me. Thank you.
Yeah, thank you so much, Shirley. And you're exactly right. It's a lot of the time with media is attracted to having some of those sort of risky headlines that, don't really share the whole picture.
Yeah. This is a question. Do you think this applies to other conditions in pregnancy?
That's a really great question, and thanks so much, Gina. I do think it seems likely, based on some conversations that I've had with people at events such as these, that it sounds like it's resonated for people more broadly in terms of, like, maybe they were having to make decisions around taking a different type of medication in pregnancy. There's a lot of overlap in some of those feelings of guilt and anxiety. There's a very strong message, in society against taking any medication in pregnancy. And so, yeah, that's, I feel like a lot of the themes were really similar. And then I think it's also resonated for women that I've spoken to that have been deciding about taking medications even outside the context of pregnancy. Kind of on the other hand, like, there's some similarities there too, that because of that stigma against medication use, in particular for mental health. And yeah, I agree that I think it'd be really interesting to understand that the potential differences, because I think there's extra layers that when those two things are put together.
Yeah. Thank
Yeah.
you. I found your presentation very validating too for a lot of listeners. So thank you.